Hello, my name is John Caridi, and I'm the Director of the Neurosurgical Spine Division at UT Health Neurosciences, and I'm going to be talking to you today about Adolescent Idiopathic Scoliosis. Adolescent Idiopathic Scoliosis, or AIS, is an abnormal curvature of the spine which is seen in young people generally between the ages of 10 and 18 years of age. It is a relatively prevalent disease and occurs in approximately 4% of the population. It has a prevalence of approximately 3 females to every male, so it is predominantly a disease of young women. The cause is unknown. However, there is thought to be a familial inheritance pattern, as 30% of children with this disease have a family history of scoliosis. So what are the symptoms of someone who's diagnosed with adolescent idiopathic scoliosis? Typically, there are no symptoms of pain or neurologic injury, such as weakness, numbness, or difficulty walking. The signs usually are visual. You see a rib hump, which is caused by the 3-dimensional curvature causing the ribs to protrude. You sometimes can see shoulder asymmetry, where one shoulder is noticed to be higher than the other. You can also see a trunk shift or a waistline asymmetry, in which the shoulders are not necessarily centered over the hips. This is the Adams forward bending test, which we'll talk about in a moment, in which you can see the noticeable curvature of the spine and the significant rib hump caused by the scoliosis. So how is diagnosis of this scoliosis made? Typically, a primary care physician will perform a 360-degree postural screening examination and note any abnormalities, such as the asymmetries that we discussed previously. The Adams forward bending test is typically utilized, showing the significant rib hump. A neurologic examination will be performed in order to ensure that there is no significant weakness or other neurologic abnormalities. Although these are rare symptoms, they can occasionally be picked up. Once this is completed, a full spine X-ray is performed in order to definitively diagnose the condition. Further workup is generally utilized, including a screening MRI, in order to make sure that there is no significant neurologic abnormality. The growth potential of the child also has to be assessed. If a child is skeletally mature, this will inform treatment options, as a skeletally immature patient needs to be treated significantly differently than a skeletally mature patient. So how is scoliosis treated? The primary way in which scoliosis is treated is observation. Curves are typically diagnosed at a very slight angle, and these minor curves can be watched with serial X-rays, and generally they don't progress and the child can go about their normal life. If the child is diagnosed with a moderate curve and is skeletally mature, or if the curve starts to progress, they can be put into a brace. The brace is a rigid plastic orthosis that the child has to wear at least 18 to 20 hours a day. Physical therapy is also something that can be utilized in children with mild to moderate scoliosis. Both the Schroth method and the McKenzie method have been proven to actually improve moderate curvatures over time. The last option is surgery. Surgery is reserved for patients with severe or rapidly progressive curves that may ultimately cause significant disability. So what generally happens in a child who has scoliosis? The natural history in a child may seem that as they grow, their spine will gradually straighten. However, the opposite is actually true. In a skeletally immature patient with scoliosis, the progression of the scoliosis can actually be quite rapid. As the child hits their growth spurt, the spine will actually curve more. In a skeletally mature patient, a curvature of less than 45 degrees will generally not progress. They will remain stable and not typically cause problems. However, any curvature over 45 degrees in a skeletally mature patient will progress at approximately 1 degree per year. This means that a 20-year-old with a 45-degree curvature will have a 90-degree curve by the time they are 65 years old. The long-term consequences of this can be profound. As the curvature progresses, the lungs can be compressed and the respiratory system can be compromised. Likewise, some of the large vessels feeding the heart and the remainder of the cardiovascular system can also be compromised, causing significant organ issues. Neurologic compression can occur as the curve progresses and cause weakness, pain, numbness, or other deficits. Other long-term consequences can include chronic pain, such as low back pain and sciatica. Postural abnormalities can also occur, such as a dowager's hump, which is seen in elderly females. When we talk about surgical correction of scoliosis, there are generally two options that are utilized. The first is the correction of the curvature with a fusion and instrumentation. This is done generally through a posterior approach or from the back. And the second option is referred to as vertebral body tethering, which is a correction of the scoliosis curvature. However, the spine is not fused and left in a dynamic position. This is done via a minimally invasive anterior approach and is demonstrated in this diagram, in which the screws are inserted into the vertebral bodies and the scoliosis is pulled into a more normal curvature. This is an example of a child with progressive disease. As seen on the left, this child has a relatively minor lumbar scoliosis. She's put in a brace and she corrects very well. However, 1 year later, her curve is noted to be significantly progressive. Her parents declined surgery at that time, and a year later, her curve has progressed significantly. You can see how her trunk has shifted over her hips, and she is no longer standing upright. She required a surgical correction with posterior fusion and instrumentation and correction of her scoliosis, and ultimately did well. This is an example of a child with severe disease who presented with a curvature in the thoracic spine of over 90 degrees. Her spine was significantly curved. Her lungs were beginning to show compromise, and her respiratory function was decreasing. She underwent a posterior fusion, instrumentation, and correction. Her lung function improved significantly, and she ultimately did very well. In conclusion, adolescent idiopathic scoliosis is a potentially life-threatening condition that is easily treatable when diagnosed and managed at an early age.